It's been now mentioned in both presentations preceding me, the importance of patient compliance to therapy, particularly for patients with chronic disease. And I want to discuss with you a particular set of new thinking and solutions that we are putting forward to overcome this problem. And I'm going to focus on the fact that these estimates vary, but around 2/5 of patients do not follow medical advice. They do not take medications as indicated, or they do not come to appointments. They do not get procedures that their clinicians think are needed. And studies also differ in this, but there's evidence of wasted and misallocated healthcare resources because of this. And a recent study has estimated $290 billion in the healthcare system at the moment being wasted or misused or being incurred as expenses for patients having complications that could have been prevented by being adherent to therapy. Poor adherence, poor fidelity to therapies that work, which are now becoming more common than in the past, also lead to patients that do not realize the value of the healthcare they sign up to receive. They may experience, for instance, the cost of taking medication for a little while. They may even experience the side effect of these medications. But because they don't take it for long enough, or as indicated, they may actually not benefit from those medications. And finally, there's a subtle challenge to a poor fidelity to treatments, and that is a challenge to the patient-physician relationship. We have heard now about the challenge of patients with chronic conditions and the need for a partnership with their clinicians. In seeking that partnership, trust, Amy has now made a big point about this in her video, trust is key. And yet, trust is undermined when physicians suspect that the patient is not following advice. And when the patient cannot actually tell the physician this because the patient suspects that if the clinician were to know that she's not following the advice, that everything will be broken up and the relationship will cease to be meaningful and therapeutic. So both parties are engaging in a less than completely open, less than completely honest relationship introduced by this problem of non-adherence. Now, we've heard that some of these problems is because people are not well educated. They do not know the facts. They do not understand the importance of some of these therapies. And so, or they because of that, they make faulty decisions. And so, some will argue that poor fidelity to treatment is the patient's fault, ultimately, and that they're basically compliant on purpose, they're intentionally non-compliant. And that the way to overcome this is through education, through better relationships, through addressing their needs and concerns by better information. And our research team has actually taken on that challenge, trying to help patients participate more actively in sharing clinical decisions and treatment decisions. And we've developed all sorts of interventions to do this. And some of these interventions can actually be found on our website. Sorry, I went too fast there. Sorry, I just went to the... I'll start again. There's a big problem with patients. So I was telling that our group has developed some tools to help people participate in shared decision making, and some of these tools are flashing up now. And I have a website, I'll leave it up for if you want to take a note, where you can actually go and experience these tools for yourself, see videos of patients and clinicians using these tools. We've measured their impact, and we have had a measurable but yet small impact on overall patients' fidelity to treatment. By all accounts, we think this probably accounts for half of the problem. Where is the other half? To tell the story of the other half, let me introduce you to John. Now, John is a made-up patient. I made up John. I thought so, at least, until after presenting this in a couple of other venues, John showed up in my clinic. And as you can imagine, I was immediately moved by the fact that, or maybe I'm thinking of another Victor Frankenstein, but all of a sudden my creation showed up in my clinic. And after presenting this to a community here in Rochester of patients, this woman came up at the end and said, "Hi, my name is Jane." I said, "Hi, well, that's not my real name," she says, "but I'm just like John." And it turns out that the case I'm going to present is nothing but becoming very typical of the practice of a diabetes doctor. You've heard of a diabetes patient. I'm on the other side, although I like to think of myself as being next to my patients with diabetes. But here's John. And so John is a 55-year-old man with type 2 diabetes. And John also was put on metformin and was put on glipizide, and also has hypertension, and he was put on hydrochlorothiazide and beta blockers. And when he takes these pills, he sometimes feels a little dizzy. He also has high cholesterol and has depression and has a bad back. He also was told to have neuropathy. That neuropathy is the pain in his feet, and he's also obese. And his doctor told him, you got to see an endocrinologist. You also probably need to see a podiatrist, an expert in your feet, and you probably have to also see a dietitian. For that, you may want to go to the Mayo Clinic. Well, that means they have to take off work and get a ride. And then, of course, what he's going to hear he needs to avoid salts, avoid fats, avoid carbs. He needs to exercise more. He needs to check his feet. How is he going to check his feet? He's obese. He has back pain. So he needs to get his wife to actually look at his feet every night to make sure that they're okay. Now, of course, when he's doing all this, he needs to also be checking his sugars, as Amy mentioned before. And his doctor just told him his sugars are too high, his LDL cholesterol is too high, his weight is too big, and he knows he's been trying to lose that weight, but he's not been able to do it. He's in pain all the time, and he can't sleep, although he's not sure he got to discuss this with his doctor. Then he realizes he was one of 3 accountants in his business, then 2, and then just him. He knows the deadline is always now, and he got to perform. And so he needs to take some work home. And he knows by looking carefully that the numbers are not adding up, and he's worried. He's worried that his company is going under, and he's going to lose his insurance, and he's going to be in debt, and he's not going to be able to pay his mortgage if he loses his job. So he's worried about his home. But the biggest worry is, in fact, at home. And when he's thinking about home, he's thinking about the fact that his daughter has come back home. And that should be a happy event, except that his daughter came back home because of difficult circumstances. Now, he brought with her 2 beautiful girls, her daughters, John's grandkids. And John is always worried about them because he knows their mother has suffered. Their mother's at home because her husband was abusing her, and she's always wasted. She's on drugs and alcohol. John is always worried about her grandkids. Will he be there to constantly support them, to take care of them? And as he's worried about this, reflecting on this at home, he opens up the mail and he gets a letter from his primary care doctor advising him that these numbers, this high cholesterol, this high blood sugar, this weight that is not coming down is really not acceptable. That this doctor is being subject to pay for performance measures that require that all the patients are well controlled. And that despite his best efforts, he doesn't believe John is doing his part of the job. And that if this were to continue, he'll have to find another doctor. Not following physicians' advice has become the number 3 cause that patients report for being fired from clinical practices. Number 1, being physically abusive to your doctor. Number 2, asking for narcotics. Number 3 is not following physician advice. So what is the problem with non-compliance for John? And I would put forward the problem is that the program that he's on is overwhelming. It does not fit in the context of John's life. But what happens when a patient like this shows up to a practice like the one he goes to? The physician recognizes that John is not achieving the goals of each of those conditions. Not getting the sugar down, not getting the cholesterol down, not getting the blood pressure down, not losing the weight. And so what do we do with patients that show up in this circumstance? We actually collaborate to co-create a program that fits better? No. What we do is we intensify the program. The patient needs more treatment, which does not help. Why are doctors so evil? Of course, doctors are not evil. What they're trying to do is they're trying to practice the best possible care they can. And the way that care is being designed these days is through evidence-based guidelines. They tend to be produced in a disease-specific fashion. So you have a guideline for diabetes, a guideline for blood pressure, a guideline for cholesterol. And each of those guidelines have disease-specific goals that the physician and the patient should achieve. And they push the clinician to organize the treatment according to these guidelines, and to refer a patient to specialists that may actually help with each of these guidelines. Now, there may not be somebody like that primary care clinician to organize the different advice that each of these specialists will provide the patient, or to coordinate those visits. I mean, imagine if for one procedure you have to go to a particular place that specializes in that procedure and only does that, and then for another procedure, for visiting a dietitian, you only go to the dietitian clinic, and that's where they do that, and you have to do this. How many times do you have to take off work and organize, take care of the kids, the pets, the house, and the transportation? So nobody necessarily is organizing this in an integrated fashion around the patient. And so poor coordination becomes a problem. These treatments become increasingly complex in terms of the treatments and their monitoring. There's decreased healthcare support, and at the same time, we're shifting towards self-management with all these devices Amy has shown us. So we're taking the complexity and pushing it to the patient. This increases the treatment burden, and there's therefore some patients who will fail to cope. At the end, there will be poor fidelity to the treatment program. Now, some of this happens because clinicians think that effective therapy means they just have to do it, and they may not have the ability to make it fit into the program. This is data from the Mayo Clinic. You can see that when a patient has a heart attack at the Mayo Clinic, 100% of those patients leave the hospital with all the necessary care. But immediately, these patients who have adequate education and have adequate resources to pay for these medications stop taking them. So we don't realize all the care that we can because we just do it, we don't make sure that it fits. We use the same treatment goals despite of the context. That was John that you met before. But maybe John doesn't have the problems at home that we described for John. Maybe there's another John that actually has the same problems at home but not the same problems at work. Yet for all three, we use the same treatment goals. And if John were 10 years younger, we'll have actually the same treatment goals. And if he was 10 years older, at much higher risk of complications, we will still use the same treatment goals. We do not tailor to context. And because we don't tailor to context, the programs may not fit. And when the programs don't fit, patients go to the experts on fitting programs to different contexts, other patients. And here's an example from one of these websites in which a patient is trying to make sure that their habit of drinking beer fits with their new medication for diabetes. And is asking for help. Why will a patient go to a community of people that are complete strangers rather than trust their doctor? It may be that these complete strangers are in fact experts on fitting, and their doctor is not. George Bernard Shaw coined this wonderful phrase, because physicians sometimes feel that the patients are being disobedient, but because they're being lazy, they don't do the work. When in fact, maybe patients are trying to do what Gandhi was trying to do with the English, which is to make them see from his point that it was in the best interest of Britain to actually let India be independent. Not fight them, it's just have them see it from their point of view. Maybe patients, by declining our treatments, are trying to let us know that there's something amiss, and they want us to see it their way. And what we are proposing in our research is to actually come up at the end of the day with a healthcare delivery designed to reduce the burden of treatment by focusing and pursuing the patient goals. And we're calling this minimally disruptive medicine. Now, what will be the elements of this? Our group is trying right now to focus on how to measure treatment burden. We have no way of knowing how burdened the patient is with all the treatments that we're throwing at them, as well as all the navigation of the healthcare system. Through Medical Home and other initiatives, we're trying to see how better ways of coordinating care and organizing care can minimize or decrease the disruption on care. By focusing on changing the way guidelines are put together so that we can realize the value of paying attention to comorbidity, we are trying to make what we're holding clinicians accountable to be more consistent with this goal of minimally disruptive medicine. And then we need to learn to prioritize from the patient's perspective. In diabetes, we've glorified controlling the blood sugars. We make all the visits, all the quality of care, all the concerns about the patient about this. When a patient shows up, the first thing they ask, what is my sugar? And that's okay, except that the visit becomes a visit to the principal, who's now going through a report card, rather than a visit about how things are going. And every decision takes this technical nature, rather than focus on how to make things fit. Rather, we like patients and clinicians to focus on the goals that matter. Can I live longer, at least prevent premature death? Can I feel better? Can I live unhindered by complications of both the disease and by the treatment? Can I make the program fit? And I'm going to leave you with this video. This is actually a video that I'm going to play in the background. It's from the Word in Your Hand project from 2diabetes.com. Manny Hernandez, which actually was shown in Amy's video, manages this. And it highlights the experience of patients with chronic conditions trying to make things fit. And as you see these hands, I will invite you to a reflection. Are these hands rejecting medical care when they're being non-compliant, as we say? Or are these hands asking for help? And I will put forward that these hands are doing both. They're asking for a transformation in healthcare that will make healthcare fit to the lives of the patients. And they're asking for our compassion, they're asking for our companionship, they're asking for our partnership, they're asking for care. And I think this is the road we'll have to travel now towards minimally disruptive medicine. Thank you for your attention.